Good Monday morning, everyone. I'm Dr. David Wild, Vice President of Performance Improvement, sitting in again for Dr. Steve Stites, our Chief Medical Officer. He'll be back with us tomorrow. We are coming to you from the Dolph Simons Jr. Family Broadcast Studio. Today, two very special guests join us. Dr. Gregory Poland, a physician scientist and founding and current director of Mayo Clinic's Vaccine Research Group, and repeat guest here on our update. And along his side this morning, his daughter Caroline, who is a licensed mental health counselor, certified trauma specialist, and founder and CEO of Poland and Associates Consulting. They've just teamed up on some fascinating work around why we think the way we do about vaccinations and what to do with that information as we're talking to those we love and care about around their preferences and concerns with the vaccine. But first, Dr. Dana Hawkinson, our Medical Director of Infection Prevention and Control, is here with our numbers. Not a bad weekend, right, Dana?
Not a bad weekend. I mean, overall, yesterday was a great day to be outside, and hopefully everybody got to enjoy a little bit of nature and be active. But as far as the numbers go, like you said, we didn't see a large increase, which we're always happy about. We never know how Monday morning will be after the weekend. But today we have 7 acute infections in the hospital, with 3 in the ICU but 2 of those on the ventilator. Still have 13 in that recovery period, but our numbers continue to creep down overall as far as active and recovery, total of 20. And then Hays is doing well as well. They have just 1 active patient in the hospital. So I think overall, if we are looking at the state of Kansas and Missouri, total cases are good, much better than they have been, much better than what Michigan is seeing right now. And in our metropolitan area, our cases continue to be under 100 a day, which I think is a good benchmark. Certainly, if we can push that lower, that'll be even better.
For sure. Well, before we jump into our conversation, any reporter questions on the line today? All right. Well, let's jump right then to welcome Dr. Poland again. I think this is the three-peat, if I count right, and Carolyn. Carolyn, it's nice to see and meet you. Thanks for joining us as well.
Thank you.
I know you've both recently worked on a study about attitudes towards vaccination that has been published and made available through PubMed and other publicly funded repositories, including the WHO COVID database. Tell us a bit about that research, why you did it, and how it played out.
I'll start. So you met my daughter, Caroline. She's really been the brains behind the operation because this involves the mental health side of things. So since about 2011 or so, we have been working together. And we started out looking at different styles that people use, and Caroline can go through some of that in making their decisions. And then in this later paper that we just published, we really looked at, again, how people think and how we might bring a human-centered design aspect to helping people think through that. And maybe later we can show the empathy tool as an example. So Caroline, you want to talk about some of the styles and the model you came up with?
Sure. So when we talk about cognitive styles, just think about how individuals perceive information or that lens with which they take in information, hear data and facts, and then make decisions. So it's just kind of a simple way that we take the information that we hear and we start to integrate that. And of course, all of the lenses that we have, whether we're talking about cognitive styles or otherwise, really impact how we make decisions. So a couple examples of that would be, the analytical style, which is how the medical profession most often presents information. It's very left brain, fact and data based. And the vaccine information sheets that you're given when you go in and get a vaccine are a perfect example of that. But while the medical profession most often presents information in that way, that doesn't mean that the general public most often takes in information that way. So another way that individuals might take in information that they might decision make through would be a fear-based cognitive style or lens, where their decision making is just based on fears, such as, I heard the vaccines are harmful, so I'm not going to get them. And so that would kind of be one of the ways that we can make decisions. Now, we have a primary cognitive style, and we also have secondary cognitive styles. So think kind of a Venn diagram, and we're impacted by a number of different cognitive styles.
And as you did this research and sort of saw how these cognitive styles played out in individuals who were questioning whether they would receive the vaccine or not, what did you find, and did it surprise you?
So our research really most focused on internal medicine residents and their perceptions and attitudes of having conversations with their patients. And what we found is that a lot of confidence increased in their ability to navigate these conversations with their patients. And I think that's been the really fun part for me as we've gone into this work together, is to be able to kind of marry the psychology and mental health with the medical, because we're whole people. So if we're going to address this issue of vaccine acceptance and hesitancy, then we need to address it from the whole person perspective, because we bring our whole selves to the table when we make decisions.
I think for me, what I really learned about from my daughter here was the typical style we saw with residents and with other physicians is when you have a patient hesitating on making a decision that you know is supported by the data and one that they should logically make to protect or improve their health. You're often at a stage where, because of the way we're professionalized, we just throw more data at them. That turns out to not be very helpful. And Caroline's model, the preferred cognitive styles and decision-making model, really shows that what we need to do as healthcare professionals is turn it around. Understand the style, the preferred style of the patient in front of us, and adapt our style to their needs.
Yeah. Along those lines, Carolyn, is there a preferred or a most common thinking or reasoning style in the general population?
Well, the really interesting thing is we don't necessarily hold to the same preferred cognitive style throughout all types of decision making. So we might be very, fear-based or engaging in bandwagoning, where we're influenced by what others are saying in one area, say vaccine acceptance or hesitancy, and we might be very analytical in another area. And so I think that's where we can be very curious about ourselves to try to figure out how we actually make decisions. We're not really taught how to go through a decision-making process and how to think or how to think about how we think. And when we can do that, we learn a lot about ourselves and the lenses that we have and how we take in that data.
The article you published speaks a lot about the stories we tell ourselves and how understanding those stories might be helpful in making decisions about our health. How would you explain that, and how we should be individually, and then also maybe for any healthcare providers who are going to see this and understand it, how can we pull those things together to help answer the questions or address the cognitive components of these decisions?
Yes, we all have these stories that are running kind of consciously and subconsciously in our minds as we decision make. And part of that is a very kind of neurobiological survival-based mechanism, right? Where we're always kind of taking in data and perceiving threats and potential threats that we can respond to. But it's really important that we understand these narratives and these stories that we're telling ourselves, because they influence our decision making and because they influence our behavior. But unless we bring that into kind of this conscious awareness where we're talking it out loud, it's easy to, again, have some of those lenses be not necessarily as healthy as they could be, or that will take us down the correct road. So when we listen to another person's stories, their fears, their motivations, and we listen to understand those things instead of listening to reply to those things, again, kind of layering that understanding and that empathy together, then we're able to meet that individual where they are at in their decision-making journey. And again, this goes far beyond vaccine acceptance and hesitancy, really to any decision that we can make. And when we can tailor our communication and our compassion and our empathy to be in line with the current situation of the individual who's making that decision, then they don't have to be defensive in their communication. And we can just meet in a healthy and respectful and compassionate way with one another as we have conversations about the decisions that we make.
It's interesting for me as an internist, I'm sure, and maybe you've seen some of these data. I've been guilty of it myself. When a physician enters into the room to talk with a patient, they allow the patient to talk for an average of something like 5 to 8 seconds before they interrupt them to get to the data piece of what the physician needs. The problem with that is that the data are not always as they seem. And one of the things that Caroline has done that I think has really been brilliant is to bring the whole concept of trauma-informed care into how patients are thinking about decisions regarding vaccines, particularly vaccines against something scary like SARS-CoV-2. And that's not something that you get to by interrupting the patient in the first 5 seconds.
As I listen to you both, that example, Dr. Poland, I think of our palliative care colleagues, people who are truly experts in listening first, to have conversations around end of life or treatment goals of treatment conversations. And you're right, they're very, very good at first listening and then helping address the fear, and maybe at some point adding a little bit of data around what does that mean to me. But it is a different approach, I think, than many as we come in and really try to make our case with the data or the information we have at hand. You've recommended a lot about listening to understand instead of listening to reply. I think that's probably the same sort of thing. But how do you actually do that? How does someone who's not trained or not practiced that skill, how do you start listening to understand?
I want to acknowledge it is hard. And again, whether we're talking about vaccine acceptance or medical decision making or conversations with our partner, kids, parents, educators, it is hard because ultimately what we want as humans more than anything is to be seen, heard, known, and understood no matter what. And when we perceive that we are being understood differently than how we are, when our fears or motivations are being swept aside or belittled, what neurobiologically we perceive that as a threat. And again, once we go into threat perception, we kick back into our amygdala, that fight or flight response, and our brain starts kind of like a smoke detector going, warning, warning. And now we need to armor up and defend ourselves. And we don't have good conversations when we're in defense mode or when we're kind of arguing or replying amygdala to amygdala. And so if we can kind of come in and sit back and be curious about what another person is saying, what are they actually afraid of? What are they actually motivated by? Because what we're afraid of and motivated by might be different than what they are.
I have seen this, and I have seen this so many times in the consultation room or the exam room where I have listened, and sometimes it seems forever, I will admit, but it's 10 minutes. And I've had patients begin to weep because throughout their entire lifetimes, they've never had a physician sit quietly and listen intently to their fears and to their story. And that stunned me, I have to say.
I think sometimes we're afraid of silence in conversation. And sitting in silence can be a really important way to navigate that, where, again, we can kind of drop our defenses, where someone understands that they have the space to speak, that their presence is going to matter in that conversation. And so if we can sit back and just let some of that space fill the room in quietness, and even just asking, what is it that you want me to know? What is it that you're afraid to tell someone else? Those kinds of questions invite the idea that I'm willing to listen and I'm going to understand and not be judgmental of where you're currently at.
Yeah. You know, that reminds me, gosh, back in medical school now, some time ago, a very experienced oncologist was our dean, and she very, very aptly reminded us that one of the most important things you could do as you interacted with your patients was enter the room and sit down at the bedside. Sit first, say hi, start there. That made a big difference as we interact with people. And I think those things, as you describe them, right, are all really important and sometimes lost in the translation of the day-to-day as we have these conversations. If we pivot that a little bit back to the vaccine conversation, does this thinking and decision-making, obviously it applies to the conversation around a COVID-19 vaccine, and it probably pertains to vaccines in general for those that are vaccine hesitant. But how would you like us to take this, both for the community, listening to us today have this conversation, but also for healthcare workers? How should we take that and apply it more broadly in healthcare?
Well, let me set it up a little bit, and then Caroline, maybe you can talk about, like, how do you assess somebody's style and then address that. But to me, I see a great gulf. On the one hand, medicine, the great mistake I think we will look back on medicine and say is that we allowed time-pressured interactions and the EMR to dictate the type of interaction with a patient. Often, unless I have to be conscious of it, I'm staring at the computer screen instead of looking to the side and addressing my patient. So I think here we have a situation where we know what the data shows. We know what works best, what our patients are most satisfied with. And in many ways, and that's why I call it the Great Gulf, we're doing the exact opposite. I got 15 minutes. I have to get through a lot of material. I've got to enter it into the EMR, and I'm hardly listening. Now, the context of this is, here we are in our own 1918 pandemic-like context. And we know we're not going to get out of this until we have a level of herd immunity probably north of 85% or so, higher than what we thought it was at the beginning of this pandemic. And we have in the US the context where 20-25% of people are hesitant or rejecting vaccines. In other words, we can't get to where we need to get out of this pandemic under the current circumstances. So how do we do that?
Well, so I think, again, we need to understand ourselves, to understand another person. One of those foundational ideas is curiosity, to be curious about our own decision-making, our own lenses, and another person's decision-making and lenses. And so to go back and just read through or just even skim through the articles that we wrote in 2011 that kind of introduced this model, the article that we just published with Allison Matthews. And several years ago, I also published an article with Dr. Emily Brunson on calling for a multidisciplinary approach, when we can come alongside together, understanding, again, that we are whole people and we bring our whole selves and motivations to the table of decision making. When we bring in this multidisciplinary perspective, when we're able to work together, we're able to create a more robust reason for change and a more robust understanding of what that process can be. So going back and being curious about what are our personal cognitive styles, and then what are the cognitive styles of our patients, to be able to go through in that chart back in the 2011 article that I wrote. We have examples of how you might hear this in your patients, and then ways forward in communication, strategies that might be most helpful with that patient. And don't be afraid to just ask. Who do you trust in your decision making? Again, what are you most afraid of? Do those fears impact your decision making? We kind of ask questions around that. It doesn't just have to be on us to diagnose what someone's cognitive style is. We could be curious about that and bring that into the conversation too, so that our patients can understand that and take that into other areas as well.
I think the other thing about some of those styles, unlike what we would prefer as physicians, where it's sort of one and done, the truth is with people who are very vaccine hesitant or even rejecting, there is no one thing that you're going to do that will help them to see or think more clearly about the decision they have to make. This is a trust building relationship in many aspects, and that takes time to do.
Yeah, for sure. Well, we'll move this conversation to include questions from the community here in just a second. But before we do, Dr. Poland, as you've been here with us before talking about vaccines, you shared a lot of information, just technical information and safety information. Is there anything you'd like to share with those watching today that you've learned since you were here last?
Many things, but I think one of the most important is we are no longer in an environment where anybody can legitimately say, well, this was rushed and I want to wait and see if it's safe, or, fill in the blank. Well over 100 million doses of vaccine have been given just in the United States. And we have not seen safety issues other than what we very quickly saw early on, which is in a very tiny fraction of people, often with risk factors so that we could be aware of it, the risk of anaphylaxis. We're talking about 2 to 4 per million, pretty much the same as other routine vaccines that we give. So we know the vaccines are safe. One of the things we really have learned over this time period since I was last with you is the efficacy of these vaccines outside of highly regulated clinical trials. In other words, how do they work in the real world? And they're stellar. I mean, I've been a vaccinologist for 4 decades. This is, if not the best, one of the best vaccines. I'm talking about mRNA and J&J vaccines that we've ever seen, particularly for a first-generation vaccine. So I do marvel that we could be in the midst of a pandemic that have taken 500,000 American lives. 1 out of every about 590 Americans is now dead of a disease we know how to prevent with a safe and effective vaccine. So, I personally feel a passion and urgency to educate as much as possible, talk to people about their fears, and help move them toward accepting vaccines.
Those numbers, just to reiterate, 1 in 590 has died, and 1 in a couple million has anaphylaxis that can be treated.
Mm-hmm. Yeah, Michael, you're pointing out something I talk about a lot. There is no risk-free decision, whatever you decide. So wisdom lies in that nexus of what are the risks of getting the vaccine and the benefits, and what are the risks of getting the disease if I don't get the vaccine. And as you just pointed out very well, they are so different that you sort of stand amazed that somebody would take the risk of disease rather than the benefit of vaccine.
It is staggering when you put it in those terms. And I think the questions that continue to come in, and I think we'll likely hear some of them here this morning from the community around safety and efficacy in my particular situation, we do just have to take a moment and acknowledge that they come from a real place, sometimes fear, sometimes I want more data, and do our best to work through those answers with whoever we're talking to.
you're pointing out something, Michael, I neglected to say, and I think it's really important. I think the vast majority of people who are vaccine hesitant are not, they're trying to make the best decision that they know how, but they need assistance in doing that. They're often stuck in fear. I mean, think about each of our own examples as healthcare providers. When we've had to give a patient, for example, a very bad diagnosis, they almost can't hear us after that diagnosis. They can't even cogitate over what are the appropriate avenues that I could take therapeutically. It just takes time for them. So I start with that idea that the vast majority of people want to make a good decision. They're just not sure how yet.
So true.
Yeah.
Well, Jill, let's bring the community into the conversation. Questions from the community this morning?
We have a lot of wonderful questions, as always, from our community. They are so bright, and some are tough. I'm going to start with on topic, and then we're going to move to general vaccine questions. I'm going to give the first question to Anil. And some of you may remember he's one of our long haulers. It was a year ago in April that he got COVID. And his question is, and his is kind of thematic. I think people are maybe even asking for specific language that you might use. But he says, what leads someone toward the conspiracy theories like the Bill Gates microchips and unreported side effects? And how can we even make progress with someone who is in that place?
Great question, Anil. Caroline, you want to start us out there?
Yeah, so we actually talk a little bit about conspiracy theories. That falls under the denialist style within that preferred cognitive styles model, where you're just disbelieving scientific facts, where they are more prone to believe in conspiracy theories. Maybe not caring what the data show, because whoever is creating the data or doing the studies isn't safe or trustworthy as well. And so what we want to do is provide very consistent messaging over and over. There's repetition involved with this. And I would say to not get into arguments over that. So if you want to be a safe or trustworthy person, you're going to have to sit back, listen to understand. So what I'm hearing you say is this, and what I'm hearing you say is this. Are you interested in hearing another perspective? I'm listening to understand you. Are you willing to listen to understand me? And when we then get the opportunity to talk, being very careful to avoid the hard sell and really pushing that. So again, this is a long-term process, a relationship and trust building process. And we really want to make sure that we are engaging in that way.
Something I've used that may be valuable to healthcare providers that are listening to us today is I'm always in the room with the computer with the patient, and I'll ask them, what's something that you're very expert on? Something that you know a lot about. And then I'll go onto the internet, and it's very easy on any topic. Select something that is misinformation or disinformation or includes a conspiracy theory around it. And I'll show it to them, and they'll say, well, that's ridiculous. That person doesn't even know what they're talking. And then the light bulb goes on for them. I'm not looking at credible sources of information. I found that very, very helpful many times.
What we really want is for people to go back to original sources. And again, I think this goes back to being taught how to think about thinking. Who are those sources that you're going to, and are they original, or are they someone's opinion or perception of something? And we want to really be able to unblend those things.
And again, I tell people, I don't know where you're getting your information, but, go to your academic medical center in your area. Look at their website. They're going to have credible information. You all are lucky. You've got Dr. Hawkinson. He is a fount of information, an expert in this. Do you think as a healthcare professional that he's going to give people deliberate wrong information? I often ask them, look at what's happened nationwide, and certainly in our own institution. Some 99% of physicians offered the vaccine get it immediately. Well, do you really think that they're taking the vaccine and giving it to their families if they thought that this offered harm and not benefit? So you kind of take them stepwise through thinking. And what you often find, as Caroline mentioned, is you can trace it back to fear. Really, oftentimes, it's almost a post-secondary traumatic stress that their lens that they're making their decision through, and helping them to see that and carefully, step by step, taking them through that thinking process is often all it takes to get them to see differently.
Isaac has a great question, I think, that follows up, and his is, what is your advice for people who are just afraid of the needles? They don't want to get the shot. And it starts with that. How do you combat that? And Isaac, my husband, used to be afraid of needles.
Well, I can tell you as an anesthesiologist, I've never had anyone tell me, stay away from me with that needle. I'm scared of it. And I have learned over time that threatening a bigger one is not the right approach. So maybe Caroline can teach me something here.
I'll give a little context. It turns out that about 15% of the population is needle phobic. That 15% includes doctors and nurses.
There's some really interesting potential options for that. And so EMDR is a type of trauma therapy that kind of restores information in your brain and addresses your belief about yourself in the world. And one of the things that we can address within the EMDR process is phobias, because they usually go back to something specific. And a belief about ourselves in that specific memory. And so needle phobia, just like any other phobia, is actually something that we can address in EMDR, where we're not just talking about what to do with it, but we're actually experiencing a physiological change about how we even think about or conceptualize that. But remember, pain is just a perception of threat. And so if we can kind of go back to understanding that there's something in us that is saying warning, warning, and telling us to fight, flight, or freeze, then we can kind of meet that with interventions that at least allow us to get through that, again, understanding that the benefits outweigh the risks.
Even simple things like distraction techniques work very well, for example, with a injection of a vaccine with a needle.
Very true. I find myself doing that a lot when, say, I'm talking to a patient before surgery and the nursing staff is getting ready to start the IV. I'll even call out, I'm going to have you pay attention to me. I'm going to keep talking. Mm-hmm. So just for a minute, you're not paying attention to them. And think about it. We do that with our children when it comes time for vaccines. This is not new to any of us, but those simple things actually are very useful.
You'll look over there. Lindsay wants to know, she said, I think that part of the argument is people say you have a 99% chance of survival from the virus. So isn't natural immunity better than the vaccine if you're not a high-risk person?
Well, there are a couple of questions there, right? First, risk of or sort of percent survival. We'll come back to that in a second. But the question around natural immunity being better or worse than vaccine-based immunity. Dr. Poland, do you want to tackle that?
This is a very fair question and a very good question. Mm-hmm. And this goes back to the question you asked me about what have we learned. What we know about virus-induced immunity with COVID is that the immunity is broad, not very deep, and wanes with time. In other words, people do get reinfected. What we know about vaccine-induced immunity in somebody whose immune system is healthy is that the vaccine response is narrow, but very deep. And we have not seen people get reinfected who have had documented good responses. Now, we're worried that over time, we don't know how much time, that somebody could fall back into a level of susceptibility but that doesn't take into account T cell immunity. So it turns out in this case that vaccine-induced immunity is superior to virus-induced immunity with far less risk in getting there. One of the things that I hear people often say is, well, I'm unlikely to die. Well, first of all, you don't get to choose that, right? We've seen people, probably because of various genetic variants, who do die or have very severe cases. Let's just assume you won't have a severe case. Even with mild illness, we have seen people be left with end organ damage and so-called long-haul COVID symptoms that seriously impact the quality of their life. That does not happen with vaccine. So again, we get back to, do you want to take this level of risk with the virus or this level of risk with the vaccine?
And just for clarity's sake, the percentage of patients who have had a COVID infection who are reporting some sort of meaningful long-term symptoms is a third or more. We've seen 40%, 42% in some of the more recent studies. So that is not an insignificant risk. And again, just for perspective, on the 99% versus 1% side, let's take it out of healthcare for a minute. I use this example often. If 99% of the checks that are cashed each day in the United States were processed correctly, meaning only 1% was incorrect, tens of thousands of checks would be deposited in the wrong bank account every day. And we would never stand for that, right? If your paycheck went to someone else and we said, 99% is good enough, you would not be a happy camper. I can nearly guarantee it. And so, yes, 99% is a great number because most do survive. But in the big picture, 1% of 330 million, if we're talking about the adults in the United States, right? That's not an insignificant number. And so the question is great, but...
Yeah, that's at 1% population-wide, which includes young people that are at point something percent. Now get up to 80-year-old people with multiple comorbidities. You're talking about 15%. So, that 1% can kind of hide the reality for those of us that are older adults.
Great. Jill?
Hi, can you hear me?
Yes.
Okay. Vicki says that she's a mental health therapist and she specializes in grief, loss, anxiety, and medical situations. And she says, thank you. Thank you for the program today. She has a question for the panelists. She says, do you predict a big wave of trauma and grief because of COVID? And she said, that's my worry. Could we encourage listeners to reach out for help if people are feeling traumatized?
Oh, absolutely. So, I want to clarify, we are all experiencing this global trauma. We are all experiencing grief and we are all experiencing loss. Trauma is simply just kind of a nervous system based reaction when we have a felt lack of safety. And so no human gets to escape this right now. This has been our reality for over a year. And the more proactive we can be about this, to go and to seek help and to seek support, we all have mental health, we all have physical health. And just like we need to be proactive and reactive with our physical health, we need to be proactive and reactive with our mental health. So it's not a failing on our part to need to reach out to a counselor in the same way that it's not a failing on our part when we go to the doctor. And I have, for the last year, really been talking about mental health as a wave of this pandemic. And I think we need to continue to talk about that and normalize that. And again, be proactive and reactive about that. That's something that I've worked a lot with companies and healthcare settings on, and kind of increasing trauma-informed care in that way.
Yeah, Caroline and I have been trading articles. We may end up writing something about this, but a number of studies in various geographic locations showing the tremendous increased need for mental health services as part of the reality of this pandemic.
And whether those needs are related to the impacts of a period of isolation or disconnection from those that we normally lean on for support, or whether those needs are related to our own illness or that of a family member, I think it will be huge. An interesting story this weekend, near misses count too. So I have a neighbor, a 90-something-year-old neighbor, who obviously has been doing everything possible to stay safe at home over the last year, and ran into the family this weekend outside as our little ones were riding their bikes. And the family said, "Did you know that Dad had COVID earlier this year?" And I did not. And I simply just said, "No, I was unaware." And then the next thing I know, there's an emotional conversation about how some of the children coming in to take care of Dad in the home so that he could stay at home actually brought it in. And although at this point things appear to be just fine, there was a very real emotional response to, we were trying to protect him, and we maybe could have put him at risk. And that was a near miss. I said, is up and fine and doing everything he was before his infection. So
True, very true.
Okay, can we transition to some vaccine questions, and then we may get back to some of the conversational questions. But Amanda wants to know, since Dr. Poland is on the line, could you talk to the durability of the vaccine time frame? And I think we might, because of other questions on here, break it down to the Pfizer, Moderna, and J&J. A lot of people have questions about how long does the vaccine actually work?
Yeah, I share those questions. As a vaccinologist, I would like the answer to those questions. But as you might imagine, by definition, we have only given large numbers of people these vaccines going back only 6-8 months, something like that. So we in fact have 6 to 7 month data yet showing no diminution in protection related to the vaccine. So what will that outer time limit be? We don't know yet. Many of us suspect the longer the pandemic goes on, the more likely the virus will become endemic, meaning that it would circulate annually, much like flu vaccine. And for that reason, a number of manufacturers have embarked on testing booster doses or doses against some of the new variants, and in one case, combining coronavirus vaccine with flu vaccine. So the only way we really can think about this at this point, since we have not been in the pandemic long enough to answer the question, will the vaccine last for 2 years? Nobody knows the answer to that question. But when we look at seasonal coronaviruses, and everybody who can hear my voice has been infected probably multiple times with so-called seasonal coronaviruses, we do know that immunity to those viruses decreases or wanes over time, and we become resusceptible. So we're operating on the presumption that that will be true. We don't know yet, but operating on that presumption, monitoring, watching, and out of caution, preparing booster doses.
A lot of those questions come from the fact that both health departments and the CDC have listed the sort of benefit timeline, if you will, of a vaccine for extending up to 6 months. And that wording is completely related to the limitations of the data we have, but I think that gets lost in the message sometimes. It gets translated to, it's only good for 6 months, and when can I schedule my 6-month vaccine so that I'm not back in an unprotected state? And that's not really the point of the wording at the moment, I think.
There are questions about the variants, a lot of them. So I'm going to put a couple of them into one question so you can have a discussion. One of the questions is, do the vaccines protect against the variants? And if they don't, will the boosters or the new vaccines have to go through trials? That's one of the questions. And the other one is, what are your concerns about young people and even children being more susceptible to COVID now? Is it the variants at work?
So this is certainly true. It'd be interesting to hear Dana's take, because you also have the experience of a very large academic tertiary care center. But the short answer is yes, particularly the B117 or so-called UK variant appears to increase viral load by as much as fourfold and appears to be about 40 to 50% more transmissible. Now that's kind of almost a twofold thing that we most don't want to happen is happening. So if you look in the US right now, while you guys are decreasing in number of cases, much of the rest of the US is now increasing, and it will come your way too, as it will to us in Minnesota. But right now, the B117 variant is predominating in the areas of the US where about 2/3 of Americans live. And we're just coming out of spring break travel and then college students going back home. We've seen gradually increasing rates of infection and hospitalization nationwide with younger kids, something we did not see with the original virus. So I think, when we talk about variants, they are each different. And in this case, the B117 or UK variant is not good news for younger people. Dana, I don't know if you have an additional comment or take on that.
Yeah, I mean, I think we don't really understand fully why that is, but certainly a lot of it has to do with the ability of the virus, that spike protein, to bind to the receptor on our body, creating a stronger bond and more likely infection. But also, we do hope and we do have some experience, whether it's basic science or benchtop research, showing that we do continue to have some good reaction, immune response to some of these variants. But we also have some real-world experience as well, and some of the data that especially Johnson & Johnson presented, and now Pfizer and Moderna are starting to present as well against these variants. And that is probably due not only to the proxy that we use to look at the immune response, which is the antibody levels, but as Dr. Poland mentioned before, the T cells. So the T cell responses in some of those areas on the spike protein, we can still garner a good immune response to. So we are hoping that you continue to have a good, efficacious, robust immune response to even some of these variants, not only the UK, but the South African, the Brazil variant. We know that there are now New York, California variants, and even a double new variant identified in India as well. So hopefully with our T-cell responses and more information that we're getting, particularly from these mRNA vaccine studies, we will continue to have some sort of robust immunity, again, to protect against the most severe cases of disease, hospitalization, and death.
Just tack on to what Dana said, there is sort of a, if you will, a gradient of protection. The vaccines are virtually 100% effective against death and severe disease. They're very good against hospitalization and symptomatic disease. Where they can tend to be of slightly lower efficacy is in preventing asymptomatic infection. But if you were going to create a gradient of vaccine response, that's exactly the gradient you'd want to have. So we can say that, I think, with clarity, is that the vaccines are very good in protecting against symptomatic disease, severe disease, and death.
Okay, a couple of more tough questions. I know that we are getting close to the top of the hour. We have a ton of questions, so I'm just going to pick a couple. Diane says that she was on the CDC website, the VAERS part, and she was pointing to data that showed cases of sudden involuntary abortions. She said doctors are saying it's a personal choice if you're pregnant to get the shot. She wants to know what your thoughts are.
That's actually a pretty clear one. So the VAERS data, or the Vaccine Adverse Event Reporting System data, is publicly available to anyone, but you have to read it discerningly. That's a passive reporting system, meaning, let's just say, for example, that I got my vaccine and I had a reaction. Michael, Dana, my daughter, and myself could all report my reaction, legitimately report it. So it would make it seem like 5 people had had that reaction when 1 person had. And the other thing is that is an attribution system devoid of causality. In other words, it's simply reporting that one had this reaction. So let's take the context of spontaneous miscarriage. In the United States, about 20 to as high as 25% of pregnancies end in spontaneous miscarriage. The reason we do phase 3 clinical trials, or the reason that we measure background rates, is to ask the question, in this case, do pregnant women who get the vaccine have a different rate of spontaneous miscarriage compared to pregnant women who do not get the vaccine? And the answer thus far is the rates are identical. So there are about 60,000 pregnant women that have registered with the V-Safe program, and we are not seeing rates of spontaneous miscarriage any different than in pregnant women who have not gotten the vaccine.
And that remains an important part of this overall conversation, regardless of the scenario described, right? We've heard this, well, there have been deaths in those who have received the vaccine. Well, of course there have been. There were going to be people in nursing homes that died for other reasons anyway, old age or other disease. There were going to be people who had car accidents or strokes or heart attacks in each of the populations that were included. And the comparison here is, does that happen more often after vaccination than it does in a group that has not been vaccinated? And to my knowledge, we have yet to find any of those sort of conditions where the number is not equal. There is not a significant risk of any of these concerns because of the vaccine, or an increased risk. But that doesn't mean that the vaccine protects you from those things either, right? If you are going to have a heart attack because you have 3 blocked arteries in your heart, the vaccine is not going to fix that problem. But it definitely isn't going to make it worse.
That headline, and if your decision-making style is a fear-based one, then you can easily imagine how that person walks away thinking, I better not get the vaccine. I'm afraid of that problem. Yeah, just what we're seeing here.
Okay, so I'm going to have one final question, and it's kind of philosophical to and thematic to several of the questions that we're getting this morning, but it has to do with, if you can't tell me how long the shot is going to last, then how can you be 100% sure it's safe? If you can't tell me one thing about the shot, then how can you be certain about other things? And I think that that's kind of thematic with a lot of the questions that we're getting this morning.
I mean, it's a good question. I'd be careful about tying them together. There are lots of things you know where you don't know answers to other questions. So, for example, probably everybody listening to me uses a cell phone. You can't answer the question for me of what does 45 years of using a cell phone do to rates of, pick something, brain cancer. You don't know. But that doesn't stop you, because of the benefit of it and having data over about 20 years that says there's no increased risk, from saying, okay, I'm not worried about that risk. So we can look at efficacy of the vaccine and say, we don't see anything since the very first clinical trial. So we're probably at about 8 months or so. We don't see any risk other than anaphylaxis. We see tremendous protection. So now if you reject those data, you can also turn it around and say, well, wait a minute. 1 out of every 590 Americans has died. 1 out of almost every 10 have gotten infected. 30 to 40% of those people are left with permanent symptoms. Which risk do you want to take? And that's where decision-making gets tough for people.
Yeah, I don't know that I have a lot to add. I think one of the frequent conversations we have around related or sort of connected data points is that things can be true, but unrelated. And so just because we can't tell you with absolute certainty if this immunity from the vaccine will last 10 months or 20 months, doesn't mean that we can't say that with all of the information we have available today, it is safe. I think the recognition that 100 million or more now, but more than 100 million doses have been administered in the United States. That's more information than we have around the safety or about the safety of so many other things that we do on a daily basis. And so the concern's real, and I'm not discounting it at all, but just this recognition that there is true, and sometimes those two truths are not related, even if they're about the same topic. That, I think, is what's playing out here.
You know, I think the other thing to say about vaccines is that vaccine side effects occur within minutes to weeks. There's a couple of exceptions. We know that people who got oral polio vaccine, we don't use it anymore in the US, sometimes developed polio a few months afterwards. We know that with influenza vaccine, a kind of paralysis that's generally temporary called Guillain-Barré can occur as long as within 6 weeks of getting flu vaccine. But we don't see vaccine side effects that occur months and years later. People have that idea in their head, but we don't have a single example of that.
Absolutely. All right. Well, thank you all for such great questions today. And I know there are conversations that so many of us are having in our professional lives and in our personal lives. I think the information that Caroline and Dr. Poland shared today will be hugely beneficial as we navigate those conversations in our own lives. For that, I personally am thankful to both of you. Tomorrow, a huge spectacle is headed this way. It's 155 tons of equipment being hauled on what's probably the largest flatbed you've ever seen, with police and a motorcade escorting the way. This entourage is bringing our long-awaited proton therapy gantry and cyclotron that will bring our proton therapy center one step closer to fruition. This is actually sort of the opposite of beam me up, Scotty. We'd like to just beam it in, Scotty. There you go, Logan, write it down. And to celebrate this, we have invited Dr. Ronnie Rotundo, our medical director of proton therapy, and our Vice President of Clinical Services and Physician-in-Chief at the University of Kansas Cancer Center, Dr. Terry Sue, to talk about this technology and the rise of cancer diagnosis that we have seen in the community, very likely linked to the pandemic. As we wrap up today, though, Dana, any final thoughts?
You know, I think our guests were excellent today. Thank you for answering the questions and coming on. It's always great to hear you, Dr. Poland. And I think one more point to that, you know, we really take a lot of pride in wanting to discuss these things with our patients and anybody who's vaccine hesitant or needs the information. We try to present the most accurate information. You know, for instance, even to Dr. Poland's point, he talked about Guillain-Barré after the influenza vaccine. Well, we know that there's higher rates of getting that process and that disease from getting influenza rather than the vaccine itself. So you are actually more at risk by getting influenza than getting the vaccine for that. But we will just continue to put out that good voice. It is hard to discuss the facts when people are getting their facts from untrue sources. And so what is the flawed sequence there of their getting the information? But we will continue to put forth the most accurate information from publicly available sources, like we said, CDC, county health, state health department websites, to continue to bring the most update and accurate information.
Yeah. Dr. Poland, any final thoughts as we wrap up today?
No, just maybe the one plea for people that can hear us. We are at a high plateau right now with the pandemic, and many of us are very concerned that we are going to see a fourth wave, just as other countries have who were in our very position. And we have 20 to 25% of the population that has rejected vaccines or is hesitant about those vaccines. And I would simply plead with you as a vaccinologist, reconsider that. Talk with your physician. Go to credible sites, as Dr. Hawkinson was talking about. I'm sure University of Kansas has information on their website, as all academic medical centers do, CDC and other sources like that. get credible information. You're talking about your health, the health of your family, and the health of your community. And we've seen one tragedy after another due to misinformation and disinformation. So I think the mnemonic still stands: hands, face, space, and vaccinate.
Yes, it does. Caroline, final thoughts today.
I again want to just reiterate everything that my dad just said. When we're going through something like this, one of the natural things that we do is just kind of go into shutdown, and we start to just feel tired. We've been talking about COVID fatigue, and we just start to make poor decisions because we start to just shut down the reality of the threat, the virus. And so let's be aware of the facts and engage in emotional regulation through the facts, but don't shut down to the facts simply because you're tired or you don't feel like it anymore. Facts don't care about our feelings, and so we really want to engage in those things mindfully and wisely. And remember that we as communities, it takes whole communities, and moving from a me mindset to a we mindset, understanding that my choices are going to impact my community and those around me as well.
Very true. I guess as we wrap up, I'm thinking a lot today about the fact that we know that the trusted relationship in many of your lives as it pertains to healthcare decisions is that relationship with an established physician or healthcare provider. And I would encourage anyone out there who remains hesitant or unsure, or even is at the point where saying, I would decline the vaccine, to have those conversations with your provider, whether that be with someone here at the University of Kansas Health System or with your primary care provider or someone that you have an established relationship with. We all are very willing to sit down and have those conversations, to listen to your concerns, to help understand your individual scenarios and do everything we can to get you, as Dana said, the best information possible so you can make the best decision for you and your family. And with that, we will wrap up today. Thanks again to Dr. Poland and to Caroline for joining us and sharing so much great information with us. Yeah. Be safe out there, everyone. We'll see you tomorrow.